All right, everyone. Well, welcome to the Best of Des Moines series, week 3. Today, I'm super excited. We're joined by Dr. Spooner from Unity Point Clinic, and he specializes in treating individuals who have experienced a concussion. And so, even though he has experience in all kinds of family medicine, that has become his specialty. And so, we're just going to have him on and share a little bit about his background, how he got into this field of study. But first, he just got back from vacation, and so we're excited to find out where did he go and what were his top 2 favorite memories from the trip.
Oh gosh. Yeah, we had a blast. It was a huge family Disney cruise. And I've never been on a cruise, let alone a Disney cruise, but I'll tell you, they don't disappoint. First thing is if you're hungry, it's your own fault, because there's more food than you know what to do with. And no, it's winter here in Iowa, and any excuse to get out and do something fun on a warm beach someplace is good for me. So we had a blast. I'd highly recommend.
And remind us, how old are your kids at this point?
I've got a junior and a freshman in high school, and I got a sixth grader. And each of them have their own place on the ship too. Like I barely saw them. They just take off and they go do their thing, and it's that's like the best part. They can't go very far. They're somewhere.
Yeah, yeah, unless they're in the ocean somewhere, which is not the
Yeah.
ideal. Oh, fun. So what all did you hit location wise? Where did the crew stop?
Disney has a couple of their own locations, their own little exclusive beaches, and so they stopped there. And then we did one day in Nassau, in the Bahamas, and one day at sea, just floating around. And so it was 5 nights, and that was a good little trip.
And he said he got back at 1 a.m. last night.
Yeah, this morning. So
This morning, yes. So no
yeah,
delays or anything. It was pretty
smooth travel. Yeah,
okay. Well, that's good because that's not always the case. Well,
sure.
welcome back. Thanks again for being with us. Yeah, just I would love to hear, even though I kind of know a little bit about your background just from hearing you speak over the years. But our listeners might not know, how did you get into medicine in the first place, and then what led you to specialize with treating concussion?
Yeah, sure. Always been really interested in health and wellness, and so in undergrad, I studied exercise, sports science. Thought I was going to be a physical therapist actually, and kind of uh, in discerning all the different options out there, found myself kind of steered more towards primary care, family medicine, and so started my journey there as a family physician, and was lucky enough to have the Navy foot some of the bill there. So I spent 9 years in the Navy, where I did my training in family medicine. Um, Found out there was this thing called primary care sports medicine too. So I went ahead and did an extra year of training in just sports medicine and kind of get more in the niche of that sort of thing. And part of my duty there in the Navy, they sent me off to Afghanistan for a year, and asked me to run a concussion center. Well, I knew some stuff, from sports. You see high school sport, see football and soccer and other concussions, but had an opportunity to really work with a pretty top-notch group of people there in Afghanistan, taking care of some pretty intense concussive injuries. And so we had physical therapy and occupational therapy, and we had psychiatry and neuropsychology and all that all in one place, and saw that it could really be done well while we were there for about a year. Came back, and about that time I was getting out, coming back to Iowa, where home is, and decided, hey, there are people out there getting the same types of injuries in car accidents and on the football field and on the soccer pitch and cheerleading and falling off their trampoline or down their stairs or whatever it is, and they all come looking similar. I would say concussions are kind of unique. They all kind of like snowflakes. They look sort of alike, but they all have their own unique properties. And so um, started to treat those people and developed a team around us here that does the same sort of thing, multidisciplinary management of concussions. And It's just an area that I'm passionate about and like to help people with, and so that's what we do.
And were you in charge of turning the Unity Point Urbandale into a concussion mecca, for lack of better words? Or when did that transition happen?
Yeah, it was really more services were more siloed back before I had come here. So we had physical therapists, in our own organization and those we partner with in the community, speech language pathologists, behavioral health people, therapists who had special training in one area or another. And so we sort of did our best to bring together as many of those people as we could under one roof. And by no means do we treat all the concussions in our own facility. We do that, but then also depending on the individual and convenience and then other special niches that have developed in physical therapy, for example, we often use a lot of our colleagues like yourself and others to help treat these folks.
So then what is a normal day like at Unity Point for you guys? Who all is on your team?
Well, we see we certainly see more than just concussions. And
Hmm.
so, I will see a collection of orthopedic, non-surgical orthopedic injuries. So, you know, sprains, strains, fractures, things like that, in both adults and children. And then we see concussions in adults and children. And in our team, we've got physical therapists who specialize more in your orthopedic injuries, maybe post-op recovery. Some specialize in, neck. Some specialize in balance and vestibular or vision problems that people might have after their injury. Others that specialize in TMJ and in jaw issues and tension and headaches and stuff like that. And we have a speech language pathologist. She sees all of our adult cognitive recovery type of cases. So think troubles with functional memory or attention or focus or executive function type stuff. So that's kind of the team we have in place right now.
And has that evolved quite a bit since you guys moved to your new Grimes location?
Well, evolution as far as the personnel, we've been pretty stable, though we continuously improve. So I think all of us have taken, another course and another course in whatever it is that we do, because there's always something new out there. And how can we work best together and, find new tools to put in our toolbox to treat folks when we see them.
I remember when I was at some point in high school, I had an injury and went to, it would have been your clinic, but I don't think you would have been back in the States yet. So I saw Dr. Mullis, who I think is still with your group. And he's been there for quite a while as well. Is that right?
Yes, Dr. Mullis is in our office. I think he started there maybe 5 years or so before I had come, and we have a new provider, brand new this year, Dr. Dan Stover. He's a pediatrician who did sports medicine, and so he'll see more of our mid-20s and younger individuals with sports injuries and orthopedics and concussions as well.
Sure. So what would your favorite be at this point? Do you kind of like getting the variety in since you've been in practice for quite a while now? What do you enjoy the
Yeah,
most?
I like the variety. Yeah, you're right. I think, every day is different. You never know what you're going to walk into. I think that's what I like about this particular specialty, so to speak, is that you might do more of a day that's kind of primary care focused and behavioral health and or headache or, other chronic pain, or, you may have one that's more concussion based, or a day where you're seeing a bunch of injuries from the weekend or the week before. And so kind of keeping it fresh, uh, which I think helps prevent burnout amongst other things. And I think that alone helps improve the way we approach people we see.
Yep. And being a part of a team so you can kind of pull from each other's skill sets and whatnot. So
Yeah.
when,
Yeah, that's being so close to each other, I think is what's not, because you can continuously talk with each other and you're just down the hallway from a colleague, and maybe you hadn't seen this before, or we want another opinion. Hey, how would you approach this or whatever? And so that's been a great um, carryover from this group.
Yeah, yeah. So when somebody does come in specifically because they've been in some kind of accident resulting in neck and head injury, what does that evaluation process look like for those patients and then transitioning to referring out or to your therapist on staff or who's treating them?
Yeah, I think each case is going to be pretty individual. So it really depends on kind of when and where they've come from. Is it fresh? Did they just get their injury a couple days ago or a week or so ago? Or is this someone who might have suffered a head and neck injury 6 months ago and they wonder why they don't feel quite right yet or why they still have, XYZ symptom? And so it starts by listening. I think that's really the key is we have longer appointment slots set apart for these head injuries, head and neck concussion injuries, because you need it in order to really figure out what's going on. So I think the first part is on us to listen and hear what is going on, the story, and what's happening. And then depending on, again, when and where they're coming from with their injury, it may look different. So if it's a fresh concussion, so for example, it's going to be more early education on, hey, how do you manage early symptoms? How do you coach and teach an individual how to kind of get back to life, maybe with some accommodations and limitations, but how do you get them headed in the right direction early, prevent some of those maybe lasting symptoms by heading things off early if you can. So a lot of it is education and early symptom management, maybe even that more than, an immediate referral to therapy, for example, because I think if you can manage some things early with some accommodations, and then people can get back. They don't necessarily even need a whole lot of other stuff. And sometimes I think keeping them too busy and just, over scheduling them with appointments early might actually set them back a little bit. So give them a little space. So those would be kind of one, example of a fresh concussion. Now, what if it's an individual who's been, 4 weeks, 6 weeks, 2 months out, and they may be a little better, but there's some things that aren't right. Maybe they have headaches, neck pain, dizziness, troubles with reading, blurry vision, focus problems. Okay, now, same thing. We listen, but then it may look more like, okay, depending on what it is that they have that's sticking around, maybe they need some help that one of our colleagues, like physical therapy or an optometrist or even massage therapy, osteopathic, chiropractor, that might, maybe they'd be able to help us with some of those things. And so depending on those issues that we find, then we would maybe refer to our colleagues in those areas. That evaluation would look, we don't, I will say early on, I always felt pressured to have a lot of tech. I think there's almost a misnomer of, it's like it's an expectation that I have all these computerized tests to do all these things. And more, I don't use hardly any of it anymore, because you just don't need to. You can often learn what you need to learn by listening, and then by doing a good physical exam. And so we do a pretty good, I think, functional vision exam and balance assessment and vestibular assessment. We don't go in the weeds with cognitive assessments. We do some basic screening, but I'm not going to have people spend a half an hour on a computer dinking around, because it doesn't give me a lot more information that's usable than if they tell me, hey, I'm having troubles focusing on this at work or at school or whatnot. Like that, that's good enough for me. I don't need to necessarily, cause more headaches and trauma just for the sake of doing a test that I don't need to do and charge you, more money for. So we're pretty conservative in that regard. I think we're just good kind of basics of physical exam history, and then we use our team and colleagues to help manage people. And the whole way along the way, it's a lot of, again, education, explain, I think knowledge is power for patients. If they just know why I feel the way I feel or what it might be that's causing this, then they feel more empowered. And I feel like that understanding takes away some of the fear in not knowing, and that really frees up a lot of the anxiety around these injuries because they can be pretty anxiety provoking injuries. You know, they don't feel right, they're dizzy, they're not sure about driving. They're worried about what their classmates or their coworkers think about them when they don't feel or look quite right. And so, yeah, these are challenging cases, but we love it because they're you know, an opportunity to really affect a person's quality of life in a positive way.
Yeah. What would you say, either with the patients or family members, are some of the biggest misconceptions that you have to continually debunk that keep coming up in those conversations in regards to how concussions play out?
Yeah, I think it's almost, and maybe it's media or maybe it's um, social media. I don't know where it comes from necessarily, and I don't know necessarily that we haven't been part of the problem at some point in our careers too. But it's almost the over pathologizing of concussions and the expectation of, oh, I got a concussion. Um, am I going to get CTE? Am I going to, this other like, for the vast majority of people, vast majority, concussion is a very temporary, um, self-resolving type of condition. It is not um, it shouldn't be thought of as anything that is construed as a long-term structural brain damage or any of that kind of thing. I really try to, you know, play down and reduce the anxiety around concussions when they do come in, because I think a lot of folks will come in and maybe they had a mild spectrum concussion, something on the mild side, but they maybe fixate or ruminate on a particular symptom or something, and that can really kind of set them off onto another track. And so bringing them back, reassuring them, validating them. I mean, all their symptoms are normal for concussion, real, but if we can bring down the stress level around some of those symptoms, I feel like people get better much quicker. And so trying to not trying to address the fear component of concussions is probably the thing that I work on the most.
Yeah. In terms of patients who, in whatever, and however it manifests with their symptoms, but they are more chronic at this point. I know within the last several years, triple PD has come out as a more popular diagnosis. Can you explain that to our listeners, just kind of what it is and how often you're seeing that with
Yeah.
patients?
Yeah. So, if someone shows up and they've got chronic symptoms, the first thing you want to do is make sure, um, one, has there been has there been a missed opportunity to manage something that's structurally or functionally not going on well? So, for example, if they've got some persistent stiffness or issues with the upper neck, cervical spine, make sure we address that. If it's a functional vision problem or they're not converging correctly or they have something there, is there a gap that could be addressed with physical therapy, vision therapy, or even a prescription for glasses or whatnot? So not just so making sure we don't miss actual, pathology in those areas. Now, once you've done that, it leaves a whole host of other things, and one of them are what we would consider more functional symptoms. And the word functional is just kind of a catch-all for things that you can't necessarily measure with a test or a scan or anything like that, but their symptoms are real. And so how do we manage that? And one of those that you brought up was 3PD, or persistent postural perceptual dizziness. So it's PPPD. It is not unlike what some of my family members are experiencing right now. There's a pretty common phenomenon called disembarkment syndrome. So you come off of a boat and you feel like you're still on the boat. And, we experienced this in the Navy. We experienced this coming off a cruise ship. And it's usually temporary, 24 or 48 hours. You feel like you're still kind of floaty, and it's really the brain kind of getting used to the world as it should be and not misinterpreting it as still the boat moving under you. But this can happen with any sort of trauma that generally often causes an acute sense of dizziness, often matched with some sort of fear trigger or an anxiety or stressor. So we see it a lot with car accidents, or falls or anything, though it can be triggered by something as simple as an ear infection or BPPV, more about the crystal in the ear business. It doesn't have to be trauma related. It can be really anything. Anything that seems to provoke a fear response matched with dizziness, and that can trigger the brain to start misinterpreting cues in giving us a sense of continuous motion or dizziness. I always talk to people about how the world's like a giant puzzle around us, and our brain has to take pieces of the puzzle from different places. So it collects some pieces of the puzzle from our eyes and how they focus on the world. They collect some pieces of the puzzle from our vestibular system, so think inner ear and that sort of thing. And then they take some pieces from the proprioceptive system, so like our feet and our knees and our hips and our joints and everything that interacts with the ground around us. And world's a pretty dynamic puzzle because it's moving all the time, and we got to put the puzzle together right and quickly enough. But if the brain is either running slower, like it might be during a concussion, or if it just is overthinking one of the puzzle pieces too much. For example, let's say the brain wants to really pay way more attention to what the eyes are telling it and not what the ears and the joints in the body are telling it. It may start to give you some funny input, and that funny input is then interpreted as chronic dizziness. And it does tend to sit closer to stress, anxiety. It is more common in people who are type A or high achievers or do have a history of anxiety. It is not a mental health disorder, but we often will manage it with components of things we might treat people who are dealing with mental health disorders, like PTSD or a variety of things like that. So we often borrow tools from other toolboxes. Sometimes we borrow tools from neurology. Sometimes we borrow tools from psychology and then physical therapy and pharmacotherapy. Medications sometimes will help. And so it's complicated, but it's treatable, though it's not without its challenges. And so that's another thing we kind of enjoy doing, is helping people understand what it is, because we have people who've not even formally diagnosed yet, because it has to be 3 months before you can diagnose a 3PD, but it is what it is before they even get there. And then you have folks who've walked in and they've been dealing with it for half a decade, and no one ever told them what it was, and they just have figured out how to cope with it. But teaching them something new about it, it gives them a new kind of fresh sense of hope, I think.
Mm-hmm.
And so, yeah.
Mm-hmm. And it's a good reminder for therapists too. I know a few years ago, I had a guy who just kind of classic labyrinthitis, but was very diligent in his exercises, more so than was prescribed. And it kind of turned into even more of a visual dependence. He was bringing his convergence in, way further than needed, and then kind of spiraled into classic, I'm dizzy all the time. Visual patterns make it worse. Prism glasses for him ended up being super duper helpful. But a lot of times if it's not managed well early on, and if there's not a lot of education of, more convergence all day long will not fix it. It might make it worse.
Yeah.
Just it is so much education and getting to know your patient and knowing what are they actually doing at home, because you're only with them for 40
Yeah.
minutes or whatever it might be. You really need to know what their lifestyle looks like.
I mean, you kind of hit the nail on the head. It's really hypervigilance, right? A lot of these individuals are hypervigilant. They think about it all the time. And then they overthink about it. They perseverate about it, and it turns into a fear-provoked thing. So there's a type of, for example, there's a term out there, neuroplastic. Neuroplastic is a term that often is linked with pain. So neuroplastic pain is learned pain. And you can think about that in many common conditions like fibromyalgia and even chronic migraine and things like that. And often it is provoked when the brain is interpreting some sort of trigger as dangerous or as threatening, and then it will manifest as more and more pain. Same thing with 3PD or things like that. Brain often is interpreting normal stimulation, but somehow under the lens of a threatening situation or something that's dangerous. And then it will then provoke more and more of these symptoms. And the more someone worries about it, is hypervigilant about it, anxious about it, the worse it will get. And people will often tell you it gets worse in stressful situations, and it sure does. And then you have to be careful not to, to pull away then and say, look, this is not just anxiety. This is not just panic. This is not just, whatever. It may not get along with anxiety and stress, but it's another condition. We just got to treat these things together. And so it's tough, because you want to be sensitive when folks come in, and you don't want to, kind of misconstrue what it is that they've come in. A lot of it, again, it's listening and then validating and then teaching. And I think if you do those three things, then people will buy into what it is you can provide to them, and then they can get better. But if you miss on those opportunities or those real key pieces of it, listening, validating, and educating, I think then people can just kind of shut off, and if you don't have their attention, then they won't listen to you,
Mm-hmm.
And I always say people don't care how much you know until they know how much you care. And so you really have to get that on these more tricky cases.
Sure. Yeah. So when you get the question of what's the timeline, like what's the timeline to return to wrestling or gymnastics or even work, how do you answer that question for patients?
If it's a recent injury, I try to set an expectation of pretty rapid recovery. So on average, most concussions metabolically, because it's really a metabolic injury, should resolve within about 2 to 4 weeks. So I often, if someone had their concussion within the last week, I suggest that they should get better within the next 2 to 4 weeks, and with appropriate limitations and precautions and accommodations and things like that. Now, if they come back in 4 to 6 weeks and they're not all the way better, it's still within the realm of normal. And I've sort of even created almost like a map of recovery and acute, subacute, advanced recovery phase, things like that, just to show that it's still normal. And then maybe those are opportunities to find some of those tricky areas that we need to address. Is it vestibular, vision, cervicogenic? What are we missing? Or whatever it is, or comorbidities, other things they've had before that are not playing well with their concussion, like ADHD, dyslexia, prior headaches, things like that might be triggered more. Many of the cases that last longer are just headaches, just post-traumatic headache. In fact, the concussion is likely over. It's just they continue to have a post-traumatic either tension or migraine-like headache, and so managing that. But back to your question. Set an expectation of recovery rather than an expectation of injury, and I think that goes a long way to help them get better quick. A lot more of my adult professional patients, I would say, though, I'm really coaching them that like you got to respect the concussion a bit. Like you can't just ignore it and blast away at your computer 12 hours a day like we all do and think it's gonna work out, and so getting them to take an active role in their recovery, I think, is important. But facilitating active recovery, I think, is important too. So, the old adage of lying in a dark room, shutting everything off forever is really not a great. Research has shown pretty clearly that is not the way we should treat concussions anymore. So, enabling people to get back into parts of their life, but with some pacing, is really the key. And so active facilitated recovery, I think, is the right way to go.
Mm-hmm. Going back to the computer screen, I don't know what you see in your clinic, but I find there's a lot of people who have, well, neck pain is obvious with computer usage, but functional vision issues with phorias and that kind of thing, just simply because their eyes are here all
Mhm.
day long. Do you see a lot of those patients, or are they not typically coming into your clinic because those are more, I don't want to say minute issues, but they might seek a physical therapist first or something like that?
Yeah, I mean, certainly what we see a lot with concussions, but I think even folks that don't have a concussion and just have chronic headaches are, some convergence insufficiency. I mean, we spend all our day on a computer, which is still pretty darn close to our face. And if it's not there, we're on our phone or something else close to us. And so um, that is a huge key or a huge cause, I think, for just ocular tension headaches. But certainly after a concussive injury or something like that, when people then try to force themselves to continue to live in that close world, can really stir them up. And so, yeah, we coach them. Ergonomics, that's a big one. A lot of people are still hunched over with their neck, you know, stretched towards their
Protruding.
computer screen. And yeah, so, and we all do it anyway, it's like, but certainly coaching people into being aware of how they hold their body in position and posture and all that. Um, and then cheap tricks like readers, like how many people come in and be like, don't usually use my readers, but no, I'm using them all the time. Like, yeah, and why it is that they feel better with their readers on. And even young people, I've sent teenagers to go get cheap readers, not to become habitually needing of them, but to as an accommodation. How can you tolerate your Chromebook a little bit better? Maybe some blue blocking readers would help for a week or two, uh, or some other tinted eyewear, or change your screen brightness and all that kind of stuff. That would just be kind of basic stuff. But if no one ever tells you to do it, you might not think to do it. So really just sharing some of that wisdom with your patients can go a long way.
Right. Going back to what you were saying about you don't need super expensive or fancy technology to get these people better.
Yep.
Yeah. When somebody comes in, what are some of the things that would cue you in for this person will most likely rehab well versus a patient who, and you might not know on the first day, but what differentiates a patient who doesn't respond quite as well and turns more into a chronic patient?
I think there's probably a couple phenotypes of individuals I can think of. The first are those that just will not slow down, will not pace themselves, and then they wonder why they don't feel any better. So the hard chargers that just won't stop, or whose employer is not tolerant of them pacing, or whose job is not conducive to pacing, and those are tough because I feel like you do have to pull back a little bit in order to recover quickly. The other phenotype or type of individual would be the wound too tighter, kind of the hypervigilant, anxious, worried um, individual that cannot be kind of calmed down a little bit, because then they perseverate on it, and perseveration on any symptom, especially these that you see with concussions, can just kind of put people in a weird place. And so um, yeah, certainly history, if you're looking just at their list of prior conditions, do they have a history of, hopefully not, but do they have prior head injuries or several of them? Do they have a history of migraines or troubles with headaches that were already challenging before? People who have attention deficit issues, ADD, ADHD, dyslexia, other learning issues growing up, depression and anxiety, particularly anxiety, tends to um, be associated with longer recoveries. And so not to expect everyone in those situations to have a longer recovery, but just having your radar up a little bit that, hey, maybe you should follow up with them a bit sooner. Don't let them linger out there on their own too much. So, facilitate a shorter follow-up just to kind of keep them reassured, keep them coached up, education, all the good stuff. So yeah, just kind of being aware of that. And you see these long enough, just kind of general age groups and situations in life that might put a person at risk for stuff. Being aware of other stressors, what's going on, and you don't have to get too into it, but be aware, like, are they, do they have a work or family or other life stressor that's also going to maybe mimic or manifest or participate in their, or in their recovery or their current physical situation. And a lot of people will come in who've been struggling with chronic symptoms, and in fact, it's really, it's got to be real. Like, this is probably not the concussion anymore. You've got poor sleep habits and work-life balance issues, and other stressors that are going on. And not that the concussion couldn't have at some point contributed to your symptoms, but let's not blame everything on that concussion you had a year and a half ago. Like, we got to clean up your lifestyle and diet and exercise and all that stuff. And if you can get them to come to that realization with you, then they can do very well.
Mhm. Talk to us
So
about your your office over off of, it's Douglas. No, it's Hickman. It's Hickman, right?
my current office,
No, no, no. Your remind me the name of it.
Solace, that little,
Yes, yes, yes.
yeah, that was a 1 year experiment.
Oh, we're done with that.
Yeah,
Oh,
yeah, we're
dang
done
it.
with that. Yeah.
Oh, shoot. Okay.
Well, because I had been doing some things that, and we still do, and I brought much of what we had at Solace over to my current clinic. But um, yeah, we've got some things that you would consider probably that live in the alternative world of treatment. But dang it, it works for a lot of people, so I just keep doing it. And
Yeah.
one of those things is called alpha stim. It's a transcranial e-stim. Maybe it's a vagus nerve stimulator, who knows? But it really calms people down, helps them sleep, treats a lot of chronic pain. And we've been using it for a decade, but it's been around for like 45 years. And so I saw it work so well with all these people who were coming in for all these, you know, injuries and whatnot. And I thought, well, how about if we just like opened it up for just anybody who has stress in their life, which is probably a lot of people. Um, but it's tough, running a business, and when people, are going to have to pay cash and not insurance for stuff like that, it's just a whole other game. So
So that's
uh,
something that insurance is still not covering. It's all a cash-based service.
it does in our office, because we
Okay.
just because we use it in a different format, and it's linked with a physician's encounter. So we're talking to you. It's an actual encounter with a physician. Where in a place like Solace, it was not. It was on its own, and so it was just a cash based thing there. Great for the people who were using it, and we try to keep it pretty cheap, and it shouldn't be. Anything we do, and this message for all you people out there who do things like that, alternative kind of things. I don't know. My philosophy is don't I don't know. Be ethical on how you profit from some of this stuff. We don't bill anymore for alpha stim than we do for a normal visit to see me, because really you're just seeing me, and I'm not going to bill you more. Acupuncture, we do it as sort of a complimentary, easy thing. We do auricular acupuncture for headache mostly. It takes me 90 seconds, and the needles are cheap. So I'd rather you not have a headache and try to get you better faster than, dime me out for another $60 or something like that. So I get it. It's a business world out there. You got to make a profit, but um, uh, as ethically as we can, I think that's what we should do to, you know,
Yeah.
help our patients. But,
That's how we are with dry needling at our clinic. I know there's a
yeah,
lot of people out there that would say charge above and beyond, but we don't end up charging more for it because one, I know
no,
it gets people better, and two, I'm already poking someone with a needle, and if they don't like needles anyway, it's like, well, I'm not gonna try and convince you that this is gonna help you, and just an
yeah,
uphill
yeah,
conversation. So, I mean, it
yeah.
just goes to show it's truly a sick care system that we're working in, because
Mhm.
these patients they can rack up huge bills, and so they, if it's not done in an ethical way, they could make healthcare providers and hospitals and whoever it might be a ton of money, which is why things like Solus or whatever it might be, that's what cash based, it takes a patient who can afford to go above and beyond to truly get better. And most people can't do that, you know?
Yeah.
But it's nice when we have patients who are able to commit to their health that much, but obviously life comes up, bills are important and
Yeah.
that. So is
Yep.
what would you say then, kind of to wrap things up, are the biggest challenges in treating these patients as a whole with healthcare? How can we do a better job at kind of bridging the gap when it is a little bit of an uphill battle?
Yeah, I think honestly, it's just working together. I think teamwork, um, it- I think everyone, not everyone, I think it's the assumption that um, at some level we're all out there competing. Um, there are plenty of people. There are plenty of broken people and patients out there. I think collaboration is a way better way than competing, so how do you find people you trust, providers, therapists, um, everyone? Who do you find that you can trust to work together to help people? Because at the end of the day, you do that, it makes you feel pretty dang good. There's nothing really. I mean, why'd we ever get into this in the first place? We didn't get it for any other reason. Shouldn't be anyway, than to like feel that like high that you get when you when you actually break through and help somebody, and they like just to see their face when they feel better or they tell you that they're so much better, whatever it is. I mean, that is why I go to work every day, and I think that's why you go to work every day. It's you do that, and I think working with each other to find those people who have a strength in this area or another, and then helping connect patients to people who might get them better fastest in the most cost-effective, affordable way. And I think that's what we do. And we all have fun doing it and help people at the same time.
Yeah, well, that's why we wanted to have you on here. We really appreciate the work that you do. And I don't think I've had a patient that I've seen that is a patient of yours as well, who has not gone out of their way to let me know how much they appreciate you or how much you have helped them. And um, so just know that you're doing a really good job for a lot of people out there, and you deserve a Disney cruise. So I'm glad you were able to take that. So,
Thanks. Thank you. Appreciate that.
yeah. All righty. Well, everyone, thanks so much for listening, and thank you for Dr. Spooner's time. If you are struggling with similar symptoms, he is at Unity Point, Urbandale, which is it technically in Grimes though? Or is it?
It's in Urbandale. It's right at the corner. Like one corner is Johnston, one's Grimes, one's Urbandale. So
Okay.
it took us about 3 months to even get our mail because no post office wanted to own us. But we finally sorted that out.
Yeah. Is the new 100th Street exit is where you can find Dr.
Yep.
Spooner. Also the internet. Give him a phone call. So anyway, thank you again, and we will be here next week again with the Best of Des Moines series. So thanks so much, Dr. Spooner.